Welcome to the fourth in the Great Lakes series of Climate and Health webinar series. It's hosted by today Michigan Clinicians for Climate Action, along with our partner organizations from Wisconsin, Ohio, Minnesota, and Illinois. We want to thank each of them for their support and their help in getting people to the webinar. And please note the contact information on the screen and feel free to follow us on social media. I want to remind everybody to join us for the fifth webinar in the series, which will take place on May 25th. It's hosted by the Illinois Clinicians for Climate Action, and the social determinants of health will be the topic of the discussion that night. My name is Lisa Del Bono, and I'm with Michigan Clinicians for Climate Action, and we're hosting the webinar tonight. Before we begin the presentation, I want to thank each of you for taking time out of your evening to join us here tonight. I also want to thank Dr. Amy Collins, Jessica Wolf, and Jody Sherman for providing guidance about how to best organize the discussion tonight. We're fortunate enough to have some of the leading experts in decarbonizing healthcare as part of our panelists tonight. I'm going to let Emily Johnson, who will be moderating tonight's webinar, introduce the panelists in just a few minutes. But first, I want to tell you a little bit about Emily. She's a graduating medical student at the University of Michigan Medical School, where she co-founded the student group White Coats for Planetary Health. And she helped create an elective curriculum about climate change and human health for medical students. She is passionate about reducing carbon emissions in the surgical spaces, and it's work that she hopes to continue as an incoming general surgery resident at the University of Colorado. Next slide, Emily. I also want to express my sincere gratitude to Healthcare Without Harm and Practice Green Health, who has pioneered the way into the space of sustainability with healthcare systems. As healthcare providers, it's our mandate to quote, "First, do no harm." And yet every one of our actions we take to provide care each day and the facilities in which we deliver care creates significant amounts of greenhouse gases and air pollution. But it does not have to be this way, and that will be the topic of our discussion tonight. As the Intergovernmental Panel on Climate Change stated, and President Biden highlighted in his Climate Summit on Earth Day, we need to reduce emissions by half by the end of this decade in order to minimize the worst impacts of climate change. But as demonstrated by our panelists today, it is in our power to reach those targets. And as healthcare organizations, we owe it to our communities that we serve to lead the way. There's no time to waste. So let's get started. Emily?
Thank you for that kind introduction, Lisa. I'm so grateful that all of you are here tonight. I want to start off with just an agenda. First, we're going to take a quick dive into describing decarbonization in US healthcare so that everyone's on the same page moving into the panelists. Then each of our esteemed panelists will talk about their own experiences with a decarbonization project. We have a few prepared questions for the panelists, and then we'll open it up to audience questions. I would recommend throughout the talk today and while the panelists are speaking, you're thinking of questions, you can put them in the chat whenever you think of them, or you can save them till the audience participation component, and we can have people raise their hands or put their questions in the chat. But let's get started. So you may be wondering, what do we mean by decarbonizing healthcare? So decarbonization refers to the reduction or elimination of carbon dioxide emissions, a greenhouse gas, from all sources. From this webinar today, we hope you'll walk away with 3 major learning points about decarbonization. The first is that the US healthcare system is a major contributor to greenhouse gas emissions. The second is that decarbonizing healthcare rather can lower costs, reduce air pollution, which causes disease burden, and help combat climate change. And the third is that there are a lot of opportunities for healthcare providers and hospital administration to lead on sustainable change. So first, I want to provide some background. The US healthcare sector produces more carbon emissions than any other country's healthcare system. We produce about 550 million metric tons. And for context, If we wanted to sequester this amount of carbon through trees, we would need a forest the size, 10 times the size of the state of Michigan to sequester our annual emissions. In the US, we produce 27% of all global healthcare emissions, and we produce about 10% emissions nationally in our healthcare sector. And you may be wondering, perhaps healthcare is inherently resource and energy intensive, and our outsized production is just a result of how big our population is. But when you contextualize these numbers by population, we produce more carbon dioxide per capita in our healthcare system than other industrialized healthcare systems like the United Kingdom and Canada. And even with all these emissions, we produce worse health outcomes than either of these countries in terms of life expectancy and infant mortality. And I just want to take a brief moment to remind people that when we talk about carbon emissions, climate change will disproportionately impact island nations and low-income countries. And here in the US, a lot of that burden will be borne by low-income communities, communities of color, and people with chronic health conditions. So the first step to reducing emissions associated with healthcare is first quantifying our current emissions. Around the world, this is done with a formal accounting system known as the Greenhouse Gas Protocol, which splits emissions into 3 scopes. The first scope, scope 1, are direct emissions, and this is typically on-site boilers and anesthetic gases. The second scope are indirect emissions from purchased energy, and this is in the form of electricity, steam, cooling, and heating used by healthcare facilities. And the third scope are other indirect emissions from the supply chain and waste disposal. All the data that we provide in this slide comes from an excellent 2019 report from Healthcare Without Harm. And I believe someone's going to throw a link to that report in the chat so you guys can check it out yourself. But here we see each of the scopes broken down by their contribution to the total emissions in the US. Scope 1 and Scope 2 account for about a third of healthcare emissions at 17 and 12% respectively, and Scope 3 accounts for the largest share of emissions at 71%. Now we're going to take a look at each of these scopes and see some opportunities we have as healthcare providers to reduce emissions. So the first, direct emissions or anesthetic, is primarily anesthetic gases. Inhaled gases are themselves potent greenhouse gases and represent a major source of emissions. This table shows the relative global warming potential of inhaled gases. Desflurane, as you can see, has a global warming potential more than 3,000 times CO2 by weight. When standardized for concentration and rate, the third column shows the CO2 equivalents from about an hour of anesthetic use from each of these gases. So you can see desflurane and nitrous oxide have a disproportionate impact. As you may not know, in most cases, these inhaled gases are actually vented directly into the atmosphere as waste gases when they're done being used. Recommendations for limiting this impact are simple. The first is for anesthetic choices, limiting the use of desflurane and nitrous oxide and limiting them to only cases where they would reduce mortality specifically compared to other options. Additionally, hospitals can consider waste anesthetic gas capture and destruction technologies. I would point people to the American Society of Anesthesiologists. They have a sustainability checklist, which provides some more details on these recommendations. The second scope, indirect emissions from purchased energy, focuses on 2 major emissions reducing solutions. The first is energy efficiency, and the second is increasing renewable energy. Healthcare is the second most energy intensive sector in the US, consuming about 10% of all energy in commercial buildings and costing billions of dollars per year. Energy efficiency in the form of retro commissioning, lighting retrofits, and occupancy sensors, among others, can result in pretty significant savings. But ultimately, the impact of energy use by hospitals is dependent on where they get their electricity. Using coal or natural gas versus wind and solar can have a big impact on your carbon footprint. Transitioning to renewable energy could involve things like installing solar, geothermal, or wind generation on site, such as Gunderson has managed to do, and which we'll probably hear about later, or investment in renewables through utility providers. I also recommend that people think about joining the Healthcare Climate Challenge, which provides a framework for thinking about energy efficiency and renewable energy. And the third are other indirect emissions. So these are primarily consisting of the production, packaging, transportation, and disposal of goods and service in the healthcare supply chain. So this includes things like food, pharmaceuticals and chemicals, medical devices, and hospital equipment. And I just wanted to briefly mention one possible solution, which is around sustainable food purchasing, which can reduce scope 3 emissions. As healthcare providers, this area connects with both our health message and also reduces climate impact. So hospitals can look at the Cool Food Pledge, which has ideas like reducing red meat, buying locally, or plant-based options. For other components of scope 3 emissions, I recommend checking out Practice Green Health, which is a membership-based organization for healthcare systems to reduce environmental impact. But so that was a brief overview of healthcare decarbonization in the US, but now let's turn our attention to the reason we're all here, to learn from the three people who've had experience doing this work. So first we have Laura Donahue, who's a first-year internal medicine resident at Northwestern University and a recent graduate of the University of Michigan Medical School. While there, she led an effort to evaluate speculums with a life cycle assessment that was published in the American Journal of Obstetrics and Gynecology. And she also conducted a systematic study of emissions related to residency interview travel, which was published in the Journal of Graduate Medical Education. The second is Dr. Aparna Bole, who's an associate professor of pediatrics at Case Western University. She's also a medical director of community integration at UH Rainbow Babies and Children's Hospital, and serves as the co-chair of the boards of Practice Green Health and Healthcare Without Harm. And finally, we have Dr. Jeff Thompson, who's a pediatrician and CEO emeritus of Gunderson Lutheran Health in La Crosse, Wisconsin. Under his leadership, the healthcare system made massive transformations to reduce carbon emissions, lower costs, and improve the local economy at Gunderson Health, which became a model for hospitals across the country. So I'm going to turn it over to you, Laura.
All right, thanks, Emily. So hi, everyone. I'm Laura. I'm an internal medicine intern at Northwestern University. And today I'm going to tell you a little bit about a change that I tried to make in medical school, the lessons that I learned and how they inform my advocacy today. Next, Emily. All right, so I like to call this chapter of my life the Speculum Saga. And you may ask, how did I, as a future internal medicine resident, get interested in speculums, since I'm used to taking care of generally an elderly and proportionately high male population? And that's a great question. So when I came to my research time in medical school, I had just learned about a style of analysis called life cycle analysis that can be used to quantify the environmental impact of products. And I really wanted to apply it to something in medicine. And I found out through the grapevine that my institution at the time, Michigan Medicine, had recently changed from metal reusable speculums to plastic disposable speculums. And I wanted to provide a sustainability argument for why we should change back. So that begs the question, why did we switch in the first place? And as a lot of change in healthcare systems it started with a joint commission review. They found that in the outpatient clinic setting, there was a lot of variability in how speculums were being reprocessed. So speculums as a medical tool are unique in that they can be either chemically disinfected or sterilized via autoclave, depending on what they're going to be used for, whether it's just general clinic use or in the surgical sector. So they found that in the clinic, there was a lot of variability. Some people were using the chemical disinfections, some people were using the autoclaves, and whenever there's variability, there's risk. And so the Joint Commission recommended that they standardize the reprocessing of speculums or the use of speculums entirely. And so Michigan Medicine at that time decided to standardize by going completely to disposables, and that's where I came in. Next. So before I jump into what the study found, I want to talk a little bit about life cycle analysis for those that are not familiar with it. It's a really cool approach, really, that allows you to quantify the environmental impacts of a product or a process throughout its entire life. It's called a cradle to grave analysis, if you will. It's actually been around for decades, mainly used in the industrial and environmental engineering world. And scientists have been able to build up these massive databases, quantifying all of the emissions associated with making, mining, molding, transporting, using all these different materials. And in recent years, it's been starting to be applied to medical products as well. And there are a lot of different aspects of impacts that you can look at with life cycle analysis, including human toxicity, water use, the production of different pollutants. For simplicity, I chose in this study just to focus on the greenhouse gas emissions or the CO2 equivalents that were associated with the use of reusable and disposable speculums. So you can see here, this is a figure from the paper that outlines the life cycle of the two different specula. For both, there is the production of raw materials, production and manufacturing of the specula, the transportation and distribution to the healthcare centers at which they'll be used. Really, the difference comes in the use phase, where with the disposable acrylic speculum, it's used once and then put into solid waste management, whereas with the reusable stainless steel specula, they can be used multiple times, either disinfected or sterilized. And then once there is evidence of wear or tear or it doesn't work anymore, then it would be placed in solid waste management. Next. All right, so this is the crux of what we found. We compared 3 different kinds of specula. The acrylic specula was the new plastic disposable that Michigan had switched to. And then we compared it with 2 different types of steel specula. The grade 304 was what had been used at Michigan in the past. And then I added on a more corrosion resistant kind of steel, grade 316 as well, that could theoretically be reprocessed more. And I compared all of these different specula using a variety of different models, comparing the different reprocessing methods, such as either chemical disinfection or sterilization with an autoclave. We compared different autoclave loading practices and ran the autoclaves on different energy grids. And ultimately what we found, you can see here in figure 2, is that the reusable steel specula became more efficient from a carbon emission standpoint after just 3 or 4 uses, which was wild to me. I knew that the steel would not immediately be better just because it's so energy intensive to mine and make and mold steel compared to plastic. But I was surprised at how low that break-even point was. I expected that we would need to reuse the metal specula 10, 15 times before they became more energy efficient than the plastic. So ultimately, I took this data to Michigan Medicine. I made the argument that switching back to metal specula would be a boon to the environment. And ultimately, they said no, which was disappointing. But at this point, looking back, I'm actually glad that they pushed back on my argument because it forced me to really examine my case more closely and make it better. Next. So these are the different aspects of healthcare decision-making that came up when I was trying to advocate for switching back to the metal specula. And I will say, I used to get very frustrated that not everyone else felt as morally compelled as I did to make environmental sustainability a priority. But this project showed me that any change that is made has to be sustainable, if you will, in a variety of other areas if it's actually going to stick. So the list that I have here is not exhaustive. I'm definitely missing some aspects, but these are the areas and facets that came up when I was that came up when I was advocating for the change towards metal speculum. So I'll start at the top, risk, which is what started this whole story in the first place. So the Joint Commission had told Michigan that it needed to standardize its procedures for reprocessing specula in order to minimize a risk. In this case, Michigan chose to move towards plastic disposables, but there's obviously a lot of other ways that they could have standardized. They could have made everything chemically disinfected. They could have made everything autoclaved. And so looking at ways in which you can standardize and make things simpler and easier to teach and to use are important things when making an argument for sustainable change. Another big aspect that plays a huge role in healthcare decision-making is obviously budget. In this particular case, switching to plastic speculum saved the healthcare system about $1,000 a year compared to the steel speculums. And that included the cost of the disinfectants, running the autoclave, paying the personnel that were responsible for reprocessing. And while that may not seem like a huge difference, those things add up. And in a different scenario, that discrepancy might be bigger or might be the opposite. Switching to a more reusable method may be cheaper in the long run, but that's another thing to take into consideration. A big thing as well that that my eyes were open to in this process was looking at the personnel and the logistics that were responsible for making anything happen within a hospital system. So when you're thinking about advocating for a change, it is so important to consider what group is going to be bearing the brunt of the work that it takes to put this change into practice. And it doesn't matter what group it is, but you need to know that group so that you can make sure that they either have buy-in or that you are creating a system in place so that it evens the load. Because if not, if it's too much work, if it's adding on to people that are already tired, burnt out, overworked, it's never going to stick. The next thing, which was really the most eye-opening to me in this whole process and why I was really excited to start on this journey, was the issue of logistics. So as healthcare professionals, we're a little blinded to everything that goes on outside of either the clinic room or the unit on the hospital floor. We go into the clean supply room, we grab a speculum, we use it, we put it on the counter. The next time we go into the room, the speculum's gone and a clean one's in its place. And we don't really think about all of the different steps that it took to get that new clean speculum there. And that is huge. And making any sort of change within that logistical system, you need to understand it. There's so many steps, such as things to consider, such as where the used speculums or other materials are being stored. Is there storage space that's available on the unit, or does a nurse or patient care technician have to take it off of the unit? Who are the personnel that are required to transport that? Is there any special transport or like PPE that needs to be involved to transport the used materials? And anytime you need to separate waste streams, that is an added level of complexity to the logistics. It's so much easier to just throw everything in the trash and have one person take one bag to the trash bin. So it's really important to understand that system. And I think that as healthcare professionals, that's something that we don't have a lot of experience with. And so I'm glad to have my eyes open to that. And then finally, and most importantly, probably is patient care and safety. So luckily for speculums, there's no data that using reusable speculums puts patients at any risk for, or any increased risk for transmission of infection patient to patient if disinfected or sterilized. So that was not an issue really for this particular change, but it could be for something in the future. And obviously I'd like to argue that sustainability is a facet of healthcare decision-making moving forward in the future. So in the end, we often can't have answers to all of these different facets when making an argument for change, and there may not be an elegant solution that can tick all the boxes, but it's still important to consider all of these and other areas as they come up when you're advocating for change. Because at the end of the day, if we're not addressing all of the concerns for the decision makers, then the change is not going to stick. So that is the end of my speculum saga, though I'll definitely be carrying forward these lessons as I advocate for changes in the future. Next. So if anyone has any questions or want to talk about speculums more, please feel free to email me.
Thanks, Laura. And next we'll hear from Dr. Bole.
Thank you. Can you hear me okay? Thank you. And Laura, that was such a fascinating take on learnings from your project. I really appreciate that. And I love that that you did that work at Michigan. I got interested in sustainability in healthcare as a Michigan med student too, and actually cold called Practice Green Health back then to ask for some help on some of the things I was interested in. And now I've gotten really involved with Practice Green Health and Healthcare Without Harm, obviously over the years. So I love that we all share a connection to Michigan medicine. I'm really delighted to have an opportunity to be with all of you today. I, for one thing, really love that we're here with leaders who are trainees, students students and residents who I think are really pushing our entire discipline in the direction it needs to go and challenging all of us to be better. I love that. It's a delight to be here with Jeff, with whom I co-chair the Healthcare Without Harm Board, and to get to really focus on something that's close to our hearts, which is the sort of unique opportunity and obligation the health sector has for climate leadership. And then finally, maybe most of all, when I was part of founding the Ohio Clinicians for Climate Action, really was a dream that we would have some regional collaboration with our neighboring states, our sister clinical societies, because the challenges and opportunities I think we face related to climate advocacy and health in our states are so closely aligned. So I think we're just really more powerful together. So I'm really loving this, this webinar series. So thank you. The project that I'm going to tell you all about is the building where I practice. I'm a general pediatrician. I practice in our academic pediatric practice, which is our resident clinic affiliated with my hospital, Rainbow Babies and Children's Hospital here in Cleveland. This is a picture up here on the upper left, and I'm actually going to tell you this story without going through the visuals yet, and then I'll click through some slides at the end to show you some pictures of the work. So I'm going to start with some background about the practice and the place and the culture that we were working with in designing and building this new building, which opened in July of 2018. So the practice is our pediatric academic outpatient practice, primary care, probably about 25,000 patient visits a year. It's a pretty busy practice. This is also the home of our women's health clinic. So it's outpatient OBGYN, a midwifery, and some additional women's health services. So at the time, we were planning on peds and women's health, needing a new home. We had kind of outgrown our home at the hospital. We also were sort of buried in the hospital in a way that was somewhat inconvenient for patients. And then there was also plans for additional construction that was going to displace us. So it was like the time was right to move. And that was back in 2016. A little bit about the demographics of our practice. Over 90% of our patients are insured through Medicaid. We have a pretty big catchment area. If you're familiar with Cleveland, all the way from the near west side to sort of middle ring eastern suburbs. So it's kind of a big ellipse. But the biggest concentration of our patients come from the east side of Cleveland and inner ring east side suburbs. The collection of neighborhoods that most of our patients come from is called Greater University Circle. And I'm going to talk to you a little bit about the place to sort of set the stage for what we propose to do. So the neighborhoods are called Greater University Circle collectively. University Circle is the name for where, like, our hospitals, our medical school, our university, a lot of our cultural institutions are located in this sort of collective area called University Circle, and the surrounding neighborhoods get their name from that place. A lot of these neighborhoods on the east side of Cleveland historically were redlined neighborhoods. As most of us know, the term redlining comes from the New Deal era practice of restricting mortgage lending to neighborhoods that were typically minority neighborhoods. So they were coded in red or redlined to indicate that they were quote unquote high risk for investment, and that really led to systematic and sort of generational disinvestment in these neighborhoods. Greater University Circle was actually the subject of a 2014, I think, special on HBO that highlighted the staggering life expectancy discrepancy between a neighborhood called Huff in Greater University Circle and a wealthy suburb just 8 miles to the east, a 24-year life expectancy between those two neighborhoods. Certainly, we're not unique in Cleveland for zip code being a better predictor of health outcomes than genetic code, but that was the poster child story that HBO highlighted. So Huff was the name of that neighborhood that was highlighted, was a red line neighborhood, is actually where our new practice is located, which is important. Just like in many cities, in Cleveland, a lot of the neighborhoods that have the worst health outcomes, some of the biggest burdens of environmental injustice and economic injustice and racial injustice in our city are the neighborhoods surrounding our ivory towers. Like, they surround our university, our health systems, these health systems that like to talk about what great care we deliver and the worst outcomes in our city. And actually, when we're talking about Cleveland, some of the worst health disparities in the country are right in our backyard. So I wanted to set the stage because about 15 years before we opened this center, there was a lot of new development planned by health systems and the universities located in University Circle, a lot of new development and new construction planned at the same time. So what happened at that time, in 2004, our local city foundation, the Cleveland Foundation, convened all of us, these East Side so-called anchor institutions, the university, Case Western Reserve, and our East Side health systems, including university hospitals, and said, look, you guys are planning $1.5 billion of investment here, and look at the income, the wealth, and the health disparities in the neighborhoods where you live. How are you going to leverage that $1.5 billion to build inclusive wealth and community in the neighborhoods that you serve? And so, to make a long story short, what grew out of that were some collective efforts around trying to incentivize local living of our employees. So we have some housing incentives for employees who live in Greater University Circle, some transportation incentives. Another bucket, so that was live local, then we have a hire local series of initiatives focused on local workforce development, and there's a lot to say about that too, but a lot of work with our HR department and some local workforce development organizations to increase access to our employment opportunities for people who live in Greater University Circle. And then finally, buy local. So how do we actually spend our dollars in our backyard? One example of a sustained outcome from the Greater University Circle initiative that came into play for our practice is something called the Evergreen Cooperatives. These are a collection of worker-owned cooperatives in Cleveland whose business model are based on goods and services that the anchor institutions purchase, and the employees actually own equity in the company, and the employees live in Greater University Circle and by and large have employment risks, like maybe have never been employed, maybe have criminal justice record, reasons that they may have high risk for not being able to connect to employment opportunities. We work with a local organization called Towards Employment on helping to connect employees to these opportunities at Evergreen. So some of the businesses are like a laundry that all of our hospitals use, a hydroponic greenhouse, energy company that does retrofits and solar installations, which I'll mention again when I talk about our practice. Okay, so that was all the work of the Greater University Circle Initiative. Now, fast forward to 2016, we were wanting to build this new practice. And because I had been doing a lot of work in sustainability for our health system, I had been involved with the Greater University Circle Initiative. And I thought, like, how could we sort of like leverage the values and culture of the Greater University Circle Initiative to make this a lot more than just a new building in Cleveland? And how could I bring my passion for sustainable design and construction to the project as sort of the clinical lead, this kind of the champion from the clinical side for this practice? So this, the location for this practice is like right in the middle of that ellipse of where our patients come from. It's about 2 miles west of our hospital. It's in a neighborhood called Midtown, which is right between University Circle and the downtown like theater district, financial district in Cleveland. It is in Huff, that neighborhood that I mentioned before, that was the subject of the HBO documentary. It's sort of infamous for race riots in the 60s. A lot, it was burned down. It was blighted. It has been the recipient of terrible environmental justice over the years. As many as 1 in 4 children who live in Huff are lead poisoned. The list goes on. When we decided to, when I was thinking about how to like really lean into clinician leadership for this practice, I did a few things. We convened something called a community advisory board that consisted of community residents in Huff, patients and families, and also stakeholder organizations like partners we work with across sectors, whether the food bank, housing authority, other like local neighborhood stakeholders from within healthcare and outside healthcare, to form this community advisory board to ask the community advisory board what we should house in the center and how it should look, what were the most important health needs to meet. The visuals in the center really reflect the city, its assets, its culture, and the people we serve. I'll show you some pictures in a minute. And then when it comes to sustainable design, so I advocated hard and won that we put an expectation in the RFP for our architects that this be a LEED Platinum building, a US Green Building Council LEED Platinum building, and also put in there that we were not interested in hearing what the upcharge would. There would not be an upcharge. It wouldn't be a line item that you could say we're going to charge you X amount more dollars for LEED Platinum building. No, because if you do it right with integrated design, there should not be a big upcharge. That's a big take-home point. Like, do not let some, facilities or, architectural firms, or, sometimes you will hear from people who maybe aren't, don't share the same interests, that, it's just going to be a big additional price tag. But, the people who really know how to do this using integrated design should not tell you that. So we put that in our RFP. A lot of great support from our facilities personnel and leadership, I should say. The whole process of design after we selected our architects, really the sustainable design process was very clinician driven. We continually made sure, and it was clinicians doing this, and I say this because I want clinicians to understand how powerful you can be, even if you're not a building expert. Like, we asked questions about how the engineers and architects would be working together from before a pen ever hit the paper to start with schematic design. That was really important. And every time they showed us design concepts, I would always ask, how does this affect energy efficiency? Have you talked to the engineers about this? What does the energy model show? I mean, I would just ask those same questions over and over again, and it really made an impact. We focused on energy efficiency, on-site renewables, stormwater infrastructure, and indoor air quality. We used Healthcare Without Harm resources to have very specific requirements for furniture and interiors for optimal indoor air quality. For all of us Great Lakes states, stormwater infrastructure is incredibly important around sustainable design. And then, of course, efficiency and renewables. So we also focused on local hiring in the spirit of Greater University Circle Initiative. And Midtown is like a place where there's a ton of new development that potentially could happen. A lot of blighted properties surrounded this site when we selected it. We really wanted to not just build this building, but catalyze additional investment in the neighborhood and make sure that that was done in an inclusive and equitable way, and was part of like a larger plan for a walkable, vibrant, mixed income neighborhood. One of the outcomes of that I'll share in my slides in a minute was a new supermarket like diagonal from this clinic that is a really awesome, accessible asset for our patients and also the rest of the community. So as I mentioned, we opened July 2018. We did succeed in securing LEED Platinum designation. Our community advisory board continues to meet 5 years later. It's an incredibly cohesive group of community stakeholders. And now one of the things I'm so excited about is the community advisory board is now focused on defining and measuring health metrics around additional Midtown development projects. So the larger Midtown urban planning sort of project. It's a multi-year development project. The community advisory board is really providing guidance and oversight around infusing health and equity into the bones of the urban planning proposal around Midtown, which is so awesome. So I just want to leave you with the fact that clinicians can be a lot more powerful than I think we give ourselves credit for. We have these very cool opportunities with building and operations to sort of integrate environmental sustainability, equity, and health in our planning. And I'm going to have you let me just show you what's on this first slide, and then we'll advance. The upper left is the front of our clinic. For anyone who knows Cleveland, this is Euclid Avenue. Our bus rapid transit line runs down Euclid Avenue. So there's a bus stop right here. It's a major artery. And then we also worked with our transit authority to reroute a major north-south bus line to stop right here. So we have one stop here and we have one stop here. Probably the most sustainable thing about our building is where it's located. And here are there's a list of sort of services. In addition to the women's health and peds programs, our community advisory board asked for a lot of the things that we were able to then deliver, which was awesome. An on-site pharmacy, high-risk OB, a vision clinic, a WIC office. We have group education rooms for things like group prenatal care. We have dental practice. It's not just dental screening, we have a dental practice. I'll tell you a little bit about our social needs navigation program called Rainbow Connects. We have an attorney from Legal Aid in the clinic, an integrated mental health program. It's like such a pleasure to practice there, actually. It's awesome. Next slide, please. So this is the supermarket I told you about. This is a rendering. I should really replace it with the actual market. Just click one more, please. So this market, this is the actual picture, the lower picture. If you look through the window, you can see a parking lot and another building, and you can kind of make out our logo. That's our clinic. It's like diagonal from our clinic. This is a neighborhood that historically has had no supermarket. This is a local urban supermarket chain in Cleveland that was very open to working with the community on deciding what they should offer and how they should design the building and services to meet the community's needs. So they actually met with our community advisory board around the design of this, which is a teaching kitchen. within the supermarket. I will say anecdotally that our community advisory board members said like they would never have gotten an audience. They didn't feel like some of them with some of the smaller organizations with this large supermarket chain without like a relatively large convener like the hospital system. So it was a really nice way we could sort of lean into our anchor institution hat to bring some of those smaller institutions to the table. So this is a teaching kitchen. It has multiple stations. Our dietitians use it to teach classes, and other community organizations use it to teach classes and to gather as well. Next slide, please. This is just an example of some of the things we do, like several times a month. There are classes. We had a bunch for Earth Month this month, plant-based recipes that people can work with our dietitians to learn how to make. Next slide. Okay, so this is the main entrance of our clinic. All of the artwork was selected by our community advisory board. I mean, we had options to choose from. A lot of these are local artists. On the far wall, there are like you can open the picture frames so that children's art can be displayed back there. And that was the CAB's idea. It's pretty awesome. So we have a lot of local schools art in the back. Next slide. This is the third floor. This is the staff break area. We never had a staff break area in our practice ever. And we now have like an outdoor dining area. There's a green roof up here that you can see. So it's like a respite area for staff. Next slide. This is the women's health clinic. It's got a little bit more of like, I would say more spa-like colors. We have more primary colors in peds, but this is the women's health waiting room. Next slide. Oh, you know what? Can you go back one more? I just want to point out one other thing. Right in the back of this, there's a door in the back of this waiting area that's actually like a little, our child life office runs that so that when people have multiple kids at an appointment, they can leave some of their kids there and have them be watched for a bit. So they can have like their women's health appointment without a bunch of kids in the room. Or if you have multiple siblings, it can make it easier to conduct a peds visit too. Next slide. These are our solar panels at the back of the building. You can see there's a large solar array here, and there's also another one on the roof of the building. It generates about 50% of the building's energy use. All of these were installed by the Evergreen Cooperative, so local workers who own the company installed these panels, which we insisted on, and we were able to accomplish that, which is really awesome. Next slide. Just to give you a sense for like how excited our community advisory board and stakeholders by extension and community members and neighbors were about the practice, I think probably the highest praise I received about this project was that people in the neighborhood said this really feels like our center. It's our center, not just your center. So this is the opening, and it was a big party in summer of 2018. A lot of these are members of our community advisory board, patients and families that you see here. Next slide. And in addition to our like coming for medical visits, like we have people who come to trick or treat at our center. It was a rainy Halloween this year. They came to trick or treat. We had tons of people from the neighborhood come to do that. Some of the kids in the neighborhood don't have a lot of places to be able to walk and trick or treat. So this was really fun. And there was a big outdoor event too. Next slide. And same thing for, I think I have there's also a holiday, like a Christmas and New Year party that people came for. I mentioned our social needs navigation program real briefly before. So what this is like many practices, we are interested in assessing what are the unmet needs our patients have outside of their medical needs. So we have a program called Rainbow Connects that helps us to assess these unmet needs. And then we have navigators that help families connect with community resources to try to help meet those unmet needs. This is a picture of the first family who came to our clinic. So it's a brand new newborn baby. It's been kind of fun. Every time we celebrate an anniversary, we get to celebrate his birthday too. Next slide. I think that's sort of where I wanted to end. Our project was recognized in Midtown Cleveland as its project of the year. We really have seen that this project has helped to catalyze additional investment in the neighborhood, and I'm really excited about what comes next for our community advisory board. Thank you.
Thank you so much, Dr. Bole. That was a really inspiring talk about the clinic. Next, we're going to hear from Dr. Thompson. Go ahead and take it away.
Thank you. And thanks, Laura and Aparna, for really teaching them everything they need to know. My role here is to give you a little idea of what we did. The first piece of it will be to talk about what we did, and then a little bit about the how, and maybe help you find a way forward. I think one of the most important takeaways is that it wasn't a project. It wasn't a project at all. It was a way to embed this level of thinking into everything we did in our organization, not just from a sustainability point of view, but from an outward looking point of view. This is a lever. This is an inspiration point, an inflection point to say, we are not about just fixing sick people. We are not going to just sit here and wait for sick people to show up. And we will, in fact, be responsible for the health and well-being of the community. So it moves out of being a project into a way of life. And you might say, well, it was great. You were a doctor, you were the CEO and the board chair. It must have been easy. Well, it should have been, but it really wasn't. Next slide. So I'm going to tell you what we did. Maybe I just wasn't so smart, but it was pretty difficult. One of the key things we did is we had a one-page strategic plan, and we spent a lot of time with the board, with our staff, with senior leaders, with community members to say, what is the purpose of this organization? And we put the purpose on the top. It was a part of every meeting. It was a part of every evaluation. It was a part of how we organized our priorities and said, our purpose is health and well-being of patients and the communities. So we can't abandon people that are sick. That's really a big part of our job, but it's health and well-being, it's patients and communities. So when you look at the list of things that Aparna had on the responsibilities of that clinic, that's what the community asked for. That's what they delivered. I mean, that was a fantastic example of delivering not what we think they need, but what they say they need, and we embedded that into how we did our work. It's an out-facing strategic plan that talks about excellence and values, and all the strategies are externally facing. It doesn't say make a lot of money. It says be affordable. It doesn't say grow to take over the competition. It says grow to serve the mission of the organization only. It doesn't say it's an easy place to work. It says a great place to work because you have a chance to serve other people. So it's that mindset of the strategic plan that was so important. So what was the problem? The next slide will show the problem. The problem that we framed was that we were the problem. We as the healthcare organization were the problem. So I didn't go to the board and said, man, I'm really worried about climate change, although I was really worried about climate change. And I didn't talk about, sea levels rising and coastal flooding, or even inner city kids. I'm in rural America, inner city kids with terrible respiratory problems. I said, we as an organization, we're putting particulate matter in the air, hundreds of thousands of pounds of it. We're putting mercury into the water and the food that our people drink and eat. We are doing this. It is our job to make this better. And we can change, and we can do that. And of course, there are a lot of people said, well, you can't do that, blah, blah, blah. And in fact, we did do that. So the way to launch on it is, my opinion, is to first frame it in the mission of the organization. The mission of most of our organizations: improve the well-being of our communities. And then the next slide says, here's how we went about doing it. Now, we didn't have this mapped out ahead of time. In 2008, I couldn't have drawn this graph, but the reason I put it up here is to show you that we started with conservation. Our first major efforts were all about conservation, non-sexy, non-get your name in the newspaper kinds of things. This is pumps and motors and reevaluations of buildings you have. It's changing out lighting. It's really dull, but it was so effective. We invested $2 million, and our return was $1.2 million every year thereafter. We spent $2 million. We got a 60% return on our money. Every time we had a board meeting to talk about our sustainability program, it turns out that slide was in my presentation because it was so important. And so we quantified everything we did. We talked about it. And of course, you'll see on there, we partnered with people, that county government, on landfill biogas. We talked about wind with construction company and Organic Valley. You notice there's a big drop. We were going very well, and we had a big drop when we built a new hospital. We had to replace our hospital that was very, very old and poorly put together. But it was only half as big a drop because we did exactly what Aparna did. We asked 1,000 questions. They built a hospital that was twice as efficient as what their original proposal was. They said our request was impossible, could not be done. And yet they, in fact, did it by constant urging. So just because you're a clinician, just because you're an administrator, don't believe you can't get in the middle of this. You can. So we partnered with governments, with county governments, city governments, state and federal government. You say, wow, the government, they're this or they're that, they're red or they're blue. And we were neither red or blue. We were about the well-being of our communities, and we worked with anybody that had the same set of values. So that was our approach. We measured hard. Go to the next slide. We measured hard, and we did get our greenhouse gases down, and we could talk about the various different scopes. These are some that we had measures for. We went from hundreds of thousands of pounds of particulate matter down to far fewer particulate matter that children who are with asthma breathe, adults with COPD, cardiac patients. We know that this particulate matter kills 60, 80, 100,000 people in the United States every year, 8 million people around the world. This is not minor activity. This is big stuff, and we are responsible for that. So it's about changing the mindset of the organization. Are we to dictate what you ought to do and you ought to do, or are we responsible for their health by being a partner with them? Now, everybody's going to talk about the money. You can't get anywhere without talking about the money. And we talked about it with our board, because the board immediately said, well, we like this idea, but we know it's either jobs or the environment, or it's our bottom line or the environment. And we just said, that's not true. That's conventional wisdom that is just not true. And if your grandmother told you things, most of that's true, but that conventional wisdom is just not true. And the next slide shows what we did was, I told you about the conservation piece. To invest in this, we took money not away from the nurse's salary, not away from the GI people's scopes or the clinic's vaccination program. We took it out of savings. Most healthcare systems in the United States have savings. We took it out of savings, and instead of having in Wall Street, how we framed it, we're going to put it into our Main Street. And people like that language. They thought that was good, but they knew our returns would be terrible. So we tracked our returns, and here's our returns over that time period. This was 2008 to 16. The return on our pretty conservatively invested savings account was 5 to 6%, and our energy infrastructure was 10 to 12%. We measured hard. This got audited by every new CFO that came in the organization, because he or she knew it couldn't possibly be true, and they would re-audit it. And oddly enough, it came out the same way. You're all saying, well, how would I ever convince my board or my senior vice president or whoever I have to work with about this? Next slide. Well, here's how we started with the board. We said it hurts people. Our job is to not harm people. We have a responsibility to our communities. We promised we could save money and decrease monetary risk. Cost of energy we thought was going up. Now with the natural gas glut, it didn't go up too much. But we saved money, and we said we can improve our regional economy. And we did that on every one of our energy projects. Next, for you trying to work with your board or your organization, you got to think who makes the decisions and how stuck are they in short and long-term thinking. The life cycle analysis of the Specula. Everything has a life cycle analysis, and there's so many opportunities to inform our people better. What are their priorities? Figure out their priorities. Is it the money, or is it the well-being of the community? Is it equity? You can build a case for so many things. Who do they trust? Do they trust your CFO? Engage her in this work then. what are they afraid of? Are they more scarcity based? Oh, we're going to lose all this. Or are they sufficiency driven? We have adequate of things. We can go after this. Think about how they're organizing. So when you go to convince people, make a list of this and how are you going to build a case? Our sustainability program that improves the health and well-being of the community broadly, especially people with less assets, especially people of color in underrepresented areas. It absolutely can help improve the well-being of many communities. Next slide talks about people that have looked at it, like Laura Cassie Thiel from New York Longo. She looked at a number of cases, but she's done some great carbon evaluations. For their university, 1% of their carbon footprint can be addressed by a great recycling program. 1%. So don't get diverted. I'm not against recycling. I'm a big fan of recycling. But don't imagine that you can give yourself a badge of courage because you have a recycling program. Nor can you let your senior leaders off the hook because they say, well, we invested in recycling. Well, it's nice. It's a start. It's a clear 1%. But see, so measuring, having the data, this isn't fluff, that you can measure and you can do that. So you have to understand what is the internal political tipping point that's going to move things forward in your organization. So, I mean, as you can guess, I can go on, and I have 1 million stories. I'll be happy to go over those in the question and answer period. Next slide. Every organization has a little bit different piece that they can take on and go after. But when the questions come, if they're really friendly questions, you need to give those to Laura. I'll take all the easy ones, and you can give all the ridiculously hard ones to Aparna. So thanks for your time. The next slide has my contact, and like both Laura and Aparna, we are happy to answer questions or help you out with anything that we can.
Thank you so much,
Back to
Dr.
you.
Thompson. I'm going to bring us back to the main screen. I don't want to take away from audience time for participation, so I'm just going to ask one question to the three panelists to get a quick answer from each of you, and then we can turn it over to audience questions. So according to the Intergovernmental Panel on Climate Change, a body of the United Nations that Lisa mentioned up front, they compile evidence on climate change. In their 2018 report, they suggested that we have 12 years left to prevent runaway climate change. This makes 2020 a crucial decade to take bold action. So this is really the crux of the question. It's a two-part. Do you believe it's possible for healthcare in the United States to achieve carbon neutrality in line with these recommendations? And what do you believe is necessary for this to occur? We can start with you, Laura.
I'm unmuted now. Okay, great. So answer to the first question, yes, simply because it has to. And maybe that's too optimistic and naive of me to say, but I also feel like it has been done, obviously, at Gunderson, like Dr. Thompson was just talking to us about. And in the American healthcare system, we have the capital, we have the technology. I think it's just a matter of prioritization, which has been hard, obviously, in the past year or so, since there are so many other just as pressing important things that we're trying to work on as a system, like COVID-19 and racial injustice. But I think all of these issues can be dealt with in tandem. But there are three things that come to mind specifically that I think need to be addressed when we're moving forward. And something like Dr. Thompson mentioned is divestment from fossil fuels. That is something that needs to be done not only by our healthcare systems, but by our healthcare payers as well, insurance companies, Medicare, Medicaid, all of that. And I think that's something that we as clinicians can really advocate for. Another thing, something that I somewhat touched on in my talk is reinventing and re-examining our supply chain. And I think that that's something that we have had a renewed interest in COVID. I think we've taken for granted in this country that all of our PPE and our supplies are just going to show up once a month or however often they're delivered, and they continue they will continue to for the rest of time. And COVID has really shown us that there are instabilities in the supply chain and that disposables may not be the best option moving forward. And so I think focusing more on picking suppliers that produce products that can fit within a circular economy, or focus more on device reprocessing in-house or with other companies that do device reprocessing is going to be incredibly important as well. And then the third thing that I think we need to focus on that Dr. Bole touched on a little bit is we need to focus on primary care and public health. So much of the emissions that come from our healthcare system are from hospitals and acute hospitalizations and acute care. If we focus on primary care and preventative medicine, that is going to be the best climate medicine as well.
I can go next, Emily, because that last point is sort of very close to my heart and is close to what I was going to say. I mean, I think, so the greenest healthcare, so the answer to the question, I think, is yes. And I agree that it also has to be yes. And the good news is that getting to yes for that question also means getting to better health for the people that we serve. I believe that 100%. I mean, the greenest healthcare is the healthcare that doesn't get used. And the way that we have more intensive healthcare not get used is to invest in prevention. That includes access to primary care. It also includes public health. It also includes the social supports and investments that prevent the kinds of so-called social determinants of health and systemic inequities that result in health disparities in the first place. So that's one thing I'll say, is that I think when we think about the policy adjustments that need to be made to support climate smart healthcare, supporting universal access to preventive healthcare is absolutely part of the solution, and moving away from our retail-oriented fee-for-service healthcare. Fee-for-service healthcare will never be sustainable and climate smart. It just won't, because the incentives are all mixed up. And we know as clinicians that those incentives also can be misplaced in allowing us to do the kinds of things we need and want to do for our patients. I can tell you a lot of the most impactful services in my practice for my patients don't generate any revenue. They don't. And if we do them right, then patients will need to come in less. So if you think about the way our retail system is currently set up, there is no internal incentive in the healthcare system to make those things happen. I'll be honest, it was a hustle of like raising money and philanthropy and, federal tax credits to make all those things happen. That is not as it should be. We should be intentional about those investments because they pay off. So that's one thing. And the other policy issue that I'll mention to support this transition is the appropriate pricing of carbon and the just discontinuation right now yesterday of fossil fuel subsidies. So fossil fuel subsidies have to end, and we cannot have a continuous continual external socializing cost and privatizing profit in the energy sector. We can't do that anymore.
Well, what they said, I'm pretty much in agreement. Of course, it certainly can be done. It's not a matter of technology or capability. It's not a matter of crashing the economy. The things that need to be done are to depoliticize health. We got to stop politicizing health. The pollution and eventually climate change related to that pollution kills people, makes people sick, makes them less productive, makes it so little children can't learn in school. This damages our society, whether you worry about national strength or long-term costs. I mean, there's just so many ways you can build this argument. We just got to take it out of political flag waving and say, this is about health and not about a political party. I can tell you that I get an opportunity to do a variety of things, and one of them's worked with greening pharmaceuticals. The big pharmaceutical $50 billion companies are falling all over themselves to get into the 2030s to be carbon neutral. They're not 2050. They're saying we're going to be there by 2030 because their competitor just said they're going to get there by 2035, and the guy before that said 2040. The value of ExxonMobil has plummeted so far, it fell off the Fortune 500 list because they're stuck in an old model. And so finance is going to make a change if we can get a carbon fee that recognizes all the disease that's caused by this and gets people on board with the true cost of using carbon-based fuels, with refunds back to individual people so that they, and small businesses, so that they don't get hammered. We have an opportunity to not get behind the rest of the world that's moving in this direction. So I think we can. It's all about will. It's all about prioritization, as was mentioned, and that's what it's going to take.
Just a quick postscript, Emily, because I meant to say something that someone mentioned in the chat asking about a national healthcare system, whether it lends itself to faster transition. In my opinion, the answer is emphatically yes. And I meant to mention that the National Health Service in the UK, to my knowledge, is the first health system to have a climate action plan, and it's a pretty ambitious one. And I think when the incentives are aligned around improved population health, it makes a lot more sense for the health sector to be able to do what it needs to do to be carbon neutral. So sorry, I just wanted to add, I meant to say that about the National Health Service, and that question prompted me to remember.
And just a really friendly addendum to add to that. Let me just add to Aparna that a national health system, if it is focused, as Aparna mentioned, on public health and the health and well-being, so that if it's not the old fee-for-service model that pays more and more the sicker and sicker you let people get, but pays for keeping people healthy, if a system like that would markedly improve our chance of becoming carbon neutral. So a national health system could do that, but it's not the only way to get there. We could get there, and for people that are worrying about it, almost virtually every country that has a national health system also has independent insurance as well. So no, you don't have to give up your insurance if we have a national health system.
I really appreciate the optimism in the answers from each of you. I agree, we really have to. That's the answer. Lisa, I want to turn it over to you to call out the audience questions.
Yeah, definitely. What an inspiring discussion. I mean, I'm just blown away by each of you. So thanks so much. I'm going to start with Dave Cam, if he has his hand raised, and he can just unmute and post your question, Dave.
Thank you. This has been a really insightful and great presentation from all of you, from somebody as young as Laura, who could be my child. Okay, I'm an old guy, but I think that one of the things that happened in COVID-19 is that we see the impact of, for example, vaccine hesitancy and the promulgation of lies about healthcare and about COVID-19, and it really brings to light how the impact on a population about their own healthcare and about what they can do about it, and all of the impacts of a nationalized healthcare system is still going to come down to individual choices. So how, these individual choices are going to be really hard for us to be able to control. How are we going to educate the population at hand about this? We all agree on a nationalized healthcare system, Medicare for all. I think that we realize the impact of a fossil fuel system and subsidies that have made this a circular pool of death. But how are we going to teach our population to do that? I'm going to take that question to you guys.
I guess I can start. So I think that is a challenge. And especially now in a country where science is almost vilified and people don't listen to research, it can be hard to imagine that people would want to listen to their doctor about certain things. But I think it really does come down to just educating our individual patients. I talk to all of my patients about plant-based diets. As summer comes up in Chicago, I mean, it was 70 degrees here today and it's not even May. So that was a little terrifying, although not gonna lie, I did enjoy the sun. But I ask all my patients in clinic, do they have access to air conditioning in the summer? Are they safe from that? And just talking to all of our patients, and then they'll talk to their family members and their community about it as well. Because I think while advocating on a broader scale is really important too, and using like editorials and social media, and that stuff is obviously very important and gets the word out to a lot of people quickly. I think we can't discount the close relationships that we have with our patients and building trust with them in that sphere, because that's going to make the most difference, I feel. But I'll leave it open to comments from other people as well.
I think that's a good start. I think the responsibility is for healthcare to find broad partners, because we have not been so humble in the past. We spent a lot of time telling people what they ought to do and wagging our fingers because, you know, somebody's a little overweight or somebody didn't exercise yesterday long enough. I think we need to humbly go to the community and say, we have a font of knowledge, we have a lot of information, but we don't understand everything. And who in the community, what service organizations, what educational people, you talk to the schools. I mean, the schools are half social service and half education. I mean, they get this. There's some fabulous partners you can make in the schools. The universities have been kind of hot and cold. Some have been wonderful, and some have been kind of sitting back and well-deserved of their ivory tower moniker. And so call them out, help them be co-anchors. And let me tell you, the business community, the business community is no more homogenous than the government is. There's some fabulous people in the business community that have long-range thinking, that are happy not to take short-term profits, that are responsible for what they're doing. So I think you need to have conversations with a broad enough group of people that you know, we modeled a lot of ours off of our advanced care planning program. We didn't have doctors necessarily having all the conversations. We had rabbis and we had school teachers and we had retired social workers. We had all kinds of people going out in the community. And so I think we're going to build it up broadly by sometimes leading, sometimes listening, but being a humble, strong partner would be healthcare's best position, in my opinion.
Well, thank you to all of you. And Lisa, we have our work cut out for us in Red State, Michigan, Red State up north Michigan, just saying.
We do, Dave, but I'd love your help in moving this forward at our hospital. Great answers, everybody. So I did have a question, an interesting question that kind of nicely segues here, which was from a non-health care person. They wanted to know what they could do to move our efforts forward as a non-health professional. You may have partially already answered that question, Jeff, but does anybody have something to add to that?
I could just jump in on that question. I think that the voices of patients are incredibly powerful in health systems. Some of my most helpful and valuable allies have been from, for example, our patient and family advisory councils, some of whom, like in pediatrics and at the Cancer Center, I found those patient and family advisory councils tend to be particularly attuned to environmental exposures and issues. So oftentimes would collaborate to advocate with leadership. But even if you're not on a patient and family advisory council, like the voice of the customer is something that really resonates. And also, I find that the voice of potential employees. So a lot of times our administrators' attention would be grabbed by either customers, like patients asking about things like what's on the menu or what's going on with our, do we have an environmental sustainability plan or not? Advocacy around green building made a big difference from the community when I was at Michigan. And then potential employees, like a lot of, I got some feedback that nurses who were being interviewed were asking about, and there's a big nursing shortage here, just like everywhere. So when nurses start asking, hey, what's your hospital doing on sustainability and environmental issues, like that gets people's attention. So I think there's a lot around like potential employees and voice of the customer that can really help move the needle in healthcare. And a lot of health institutions are competitive with their neighbors. So it's super helpful when a customer says, hey, you know, the Cleveland Clinic is doing X, Y, and Z. What are you guys doing? It really is. So I think it's helpful when the customer, when you call the patient advocacy line and ask questions about our environmental commitment, it makes a difference. It is heard.
That's great. Anybody
I
else want to
agree
add
with
anything?
Aparna. That is, yes, I think Aparna's exactly right, and that is the most powerful voice. Groups of patients, groups of the community. The second group that I would target would be board members. That and you might say they'd be first, but Aparna's really right. You get a steady flow of information coming in from multiple directions. That is very powerful. But find board members. Boards have both clinicians, often clinicians and community members on them, and they can be wonderful in helping you ask questions in rooms that you otherwise can't get into. And so I think work on that. And of course, there's other leaders that you happen to know from other pieces. But I think talk with them, be a part of them, and understand. And then, you know, maybe the leader in your business that you're a part of, whether you're in education or manufacturing or another service or governmental, if you can convince your leaders to talk to the leaders of the health system, that's an advantage as well, or talk to the board member of the health system. So there are many pathways in, and the more pathways that are working at the same time, the better.
Excellent. Okay. We had a couple questions, I thought, or a couple statements that were sort of interesting, in terms of one surgeon mentioned that she had insisted on using reusable trocars for laparoscopic surgery. Another mentioned the complexity and outcomes of minimally invasive abdominal thoracic surgery has been greatly improved by the advancement of laparoscopic instruments and robotic surgery. The example of pelvic speculums may not be equivalent to the study you did, but since the number of these procedures, over 1 million per year in the US alone, and their detritus is hard to quantify, do you foresee how there could be an elegant study put together to, you know, determine the potential outcome of, you know, using more sustainable practices there? And before you comment on that, Laura, the other one that was very interesting was another person who said back in the day when we changed from glass IV bottles to plastic bags, that was a big change. And she wonders if there would be data around that and how that affected greenhouse gas and waste. So now I've just asked you to answer all the questions in the world about sustainability.
Yeah, let's go. I'm ready. So to answer the first question, there have actually been already a lot of really elegant life cycle assessments done. One in particular that I'm thinking about is one out of Cassie Teal's lab with Dr. Eckelman as well, that compared, that did a life cycle assessment of hysteroscopies and hysterectomies in the US as well. And then I actually just flagged a article on my to read list that is a systematic review of the carbon footprint of surgical operations as well. So I am happy to compile a list of good LCAs for surgical practices as well, but they have been done. People are working on them. Mine is by far not the first LCA in medicine. I think Dr. Bole, you mentioned that the NHS has really been a leader in reducing their carbon footprint, and they use a lot of life cycle assessments to drive their decision making. So they definitely, this style of analysis can be used to focus on more complex processes and procedures as well, not just one specific tool. And to answer the second question about the glass IV bottles, that actually brings up to a point of something that I'm really passionate about, which is the circular economy in medicine. And that is, for those who are not familiar with it, it's focusing on a supply chain where all of the materials that are used in the hospital or the clinic, all of those materials can be taken back by the manufacturer and reused and remade into similar products. So it's truly a circular zero waste stream. I don't know if that was actually the case when glass IV bottles were used, but it would not be an inelegant solution to try that again. But when I think about as an internal medicine resident, I prescribe so many IV medications, and they all come with the plastic tubing and the plastic bags, and it's all the same component of plastic. So it easily could be collected and sent back to the manufacturer, I would think. But this is something that I personally am going to look into a little bit more as well. But I would be interested to look into that and see if glass would be a better alternative.
I think one of the, and maybe I'm reading too much into the question, that was a great answer, but I think there was something in the question too about linking outcomes to the, so it's like if there's a life cycle component from the standpoint of the process, but also a clinical outcome. I think there was something in the question about that. And I think that would be a really fascinating angle. I'm aware of a lot of the LCA literature that you mentioned, but there's not as much as I think there could be linking, like including information about outcomes when there is a markedly different life cycle impact. It's not always applicable. Like some of the studies, it's not applicable, but sometimes it is. And I think it would be really interesting. And it makes me think about that, how especially compelling that can be. A good example is when you think about when we were going through a lot of the pitching of retrofitting operating rooms with LED lights, which is no longer a point of contention, but it was a point of contention. It saves a lot of energy, but I think what is a winner about the argument of retrofitting those lights is that it makes the room more comfortable and the quality of the light is better. It makes the less waste heat, makes the surgeons less sweaty, and they don't have to then like turn the air conditioning way down and then heat the patient back up. And there is a clinical outcome. It's not just about surgeon comfort. I mean, if the patient isn't getting cold, it's better for the patient. So that I thought was a pretty compelling argument for linking a clinical outcome with something that also clearly had a better environmental footprint. The IV example makes me think of some of the consequences of using plastic products. Like in our nurseries, a lot of us are wanting to move away from phthalate infused. A lot of those PVC bags are infused with a plasticizer to make them soft. It's a phthalate, and the dose of the phthalate that leaches out of those bags is clinically significant in neonates. And so many nurseries are trying to move away from that. So just thinking about like, that's an unintended like clinical consequence of that shift. And so I think it's a fascinating idea to think about how we could do more explicitly linking clinical outcomes with those LCA analyses. And I think it's a great idea.
And from the Speculum side of things as well, we didn't get the chance to include this in our paper, but we did do a formal study surveying patients and OB-GYN providers as well. And the patients really preferred the metal speculums from a comfort standpoint as well. The plastic ones tended to have like sharper edges that they reported, and opening them had a very like jarring, ratcheting up sound. And I mean, a pelvic exam is something that is incredibly sensitive and traumatic for a lot of patients. And so any way that we can make that easier and more comfortable, I think is important too. So that would be another case for metal.
It's a great example of to the question about non-clinician voices. Like it's really powerful if you as a patient, and I agree, I think the plastic speculums most patients think are less comfortable, but to have your patient say, why did you switch to those plastic speculums? They're really uncomfortable. They're pinchy and they're sharp and I don't like the sound. And I mean, that's really powerful. Probably like more powerful than a lot of the other arguments, honestly, related to that. So anyway, just another good example.
Well, I really want to respect everyone's time tonight, and we're actually coming up on 8:30. And so I want to take a moment to, again, thank all of our panelists. You guys gave really inspiring talks about the different components that we can think about when we're trying to decarbonize our own health systems. I really appreciate you each taking the time to give your perspectives and experiences today. I also want to thank Lisa and the Michigan Clinicians for Climate Action and all the other climate action groups that sponsored the Great Lakes Climate Series.